I'm going to show you when the rubber meets the road, when we take the technologies you've heard earlier today. It's funny because they are actually aligned very closely with what actually we do and what happened and some decisions we're going to make going forward. And you can contact me if you want any more detailed questions, but I'm not going to go into any deep technology details. This is intended to tell you what happened. And then we can go from there. And I'm hoping to leave plenty of time for question and answers and some interaction at the end. Okay, so anyway, my name's Ron Gilbert. My title is Manager of Enterprise Imaging and Informatics. And what that means is that I am the one responsible for making sure any provider and any staff member can see images, radiology images, cardiology images, and any other images that we happen to have in our image repository throughout the entire enterprise. And I'm going to give you a little bit of overview what that looks like. So the agenda today is pretty simple. Just want to give you an overview of what it was like before COVID and what the workflow we did, so you have some point of reference. And then also when it got locked down, what did we do? How did we manage things? Also, I went to a little sidebar on what the IT support for the remote work looked like and how it evolved, and then also how we have come since the restrictions have been released and we're not so locked down, even though we still have rules. What is it like now and what it might be in the future? And then I'll leave some time for some questions and answers. So, who is Wellstar? We're a not-for-profit community health system. We also have educational programs that are tied with universities, but that's not our primary focus. We have a huge footprint in Atlanta, roughly 1/3 of the healthcare needs, and mostly to the west of the city and some downtown. We have 11 hospitals, 10 emergency departments with level 1, level 2 trauma centers. Comprehensive stroke centers is 4 of those, to where we can actually fix strokes. 300 medical office locations that are all tied into our health network, 21 imaging centers, and 17 urgent care centers, which if you've ever had an urgent care centers, they have the same needs that emergency rooms do, because the patient comes in there and needs an immediate answer and gets treated. So we have to go just as fast on those as we do emergency rooms. And then there's 5 health parks, which are comprehensive centers that have primary care physician specialists, and then also places to get treatment and diagnostic imaging. So that's kind of where we do roughly in radiology, we do about 1.5 million procedures a year. If you do the math, that's going down to about 300 an hour throughout the whole health system. So I just wanted to impress upon you that we have a lot of data. And if you've ever dealt with imaging, the imaging data, is not streaming data like you think. It's very large objects that we have to actually stream. Okay, before healthcare, before COVID hit, I'm just going to give you a little overview of how the health system worked. And I have some workflow diagrams to kind of help you visualize. But we used to have system-wide meetings, and they were teleconferences. That's only when we had the whole health system involved. Representatives from all 11 hospitals, so forth. We would do those on teleconferences because we have so many miles between some of our hospitals. We have hospitals, not only in Atlanta, but we have them in Griffin and LaGrange and Alpharetta, north, south, east, and west of the city. So it wasn't practical to have in-person meetings with everyone. But most site meetings that were done at each facility were in person all the time. It was kind of expected you'd be there. So we're constantly walking down the halls going to meetings. And all the patients got to see their actual providers at the bedside if they were admitted or in the emergency room, or if it was in a doctor's office, they would come see them in person. And that was just the expectation. And then all the visits and the procedure volumes, was continuing to rise as the population expands, needs, maybe we win some market share. But we have never seen a reverse in the volume. It was just constantly rising at a steady pace. In imaging, we saw it going up between 5 and 7% year on year. So that's what we're experiencing there, and that was going back for early 2019, I believe. Okay, now what did the workflow look like? And now just to show you, I show you kind of the little steps that are taken, and I'm going to reference these in every case. But then what was the IT systems we used? Now the first part, essentially right here was the patient arrived in registration. They were in person, they were standing in the window, and then they would register and take their information. Sometimes they would fill in online before their appointment if they had that capability, so you wouldn't have to go through as many questions. And then when they arrived, you would sign some forms, give your insurance information and so forth. And then that was how you entered the system. You were now in the electronic health record as an ADT, admissions discharge transfer record. And then you would go sit down and you wait your appointment time, and then either a nurse, an RN. I hope you understand the abbreviation, medical assistant, RN, electronic health record. We thrive on those. You know how it goes in healthcare. So you'll see a nurse or you'll see a medical assistant who will then just say, hey, why are you here today? And tell them, what can we do for you? And then also ask you about your medical history and your medications you're taking and so forth. If you're an existing patient, they already know what you are taking. They'll say, are you still doing this? And then anything you've added to this. Sometimes you can do that online and add all that and save some conversation. But that's just kind of that interaction. You're getting history and vital. They'll take your vital signs, your temperature, your all the things, stuff like that. And then they'll go ahead and put the record in the EHR, and they'll put a note in that you're ready for the provider, which could be a doctor, or it could be a nurse practitioner or a physician assistant, depending on where you are. Urgent care centers tend to have nurse practitioners and physician's assistants, and the doctor's offices tend to have the medical doctors as well as inpatients. So we would do this. So patients would always go to a facility. The facility will also practice universal precautions, which means we treated everybody as infectious. So we would always, wash our hands. We would be careful, getting too close. Those are things that we have always done, because you got to understand that healthcare people have gone through SARS, MRSA, AIDS, tuberculosis, all of these other infectious diseases that have been out there, and you never know when one's going to show up, so you can't assume they don't have it. So we've been protecting ourselves for a long time. Only did when they had a droplet precautions or contact, infectious process, did we start putting gowns and gloves on. And if we ever did have to come in contact with blood or anything, possibility of it, then we would glove up also and possibly put goggles on. So this was always done. And our schedule was usually full. If you were at a provider's office, there was not uncommon to have a 2 or 3 week backlog for outpatient procedures. Now, if you're emergency, of course, you go in and they will see you in order of criticality. But if you just wanted to follow up outpatient, then you can get one for maybe 2 weeks or possibly 1 week if depending on what you needed. So the provider would come in and they would use all of the history that you've gotten, what you've given them, what the nurse found out, and then would look at you, maybe do some examinations depending on what they thought you needed. And then they would say, order either diagnostic tests, laboratory or radiology. If they thought you needed medications right then, they would e-prescribe those electronically. And then they might refer you to a specialist, especially if it's a follow-up appointment and you came back for something else. Like this, they have the results of the x-rays in the lab. They say, okay, I think you need to go see an orthopedist, and then they'll set you up with that. And all of that will be done through this tablet, like I show you, computerized provider order entry. Okay, so that is kind of how we handled things before COVID. All right, boom, COVID hit. All of a sudden, the mandates we're locked down. We can't see any. We can't risk any more of patients that aren't real critical. Outpatient procedures were starting to become canceled, like mammography, if it was routine. Now, if they had active process, then we look at that. But elective surgeries, cosmetic surgeries, things like that, we just stopped doing. Non-essential staff stopped reporting to the work site. If they had a job that they could do remotely, then they were in luck. But if it was something like, you're the receptionist in a mammography center, you might have gotten furloughed. Now, for those who did still work on site, then we started using protective personal protective equipment, which would be gowns, masks, all kinds of things like that. And you try not to get infected. And what was more worrisome was you were worried about infecting your loved ones. Like, we have always been protecting ourselves from potentially getting infected, but now it was really scary when you come home. Most of the providers would basically strip down in their garage, or they might even run straight to the shower, leave their clothes there, because they didn't want their loved ones to touch anything that they had that was in the hospital. And it wasn't uncommon for physicians to get apartments near the hospital and not go home at all. So, because it was very contagious disease. And that put a lot of stress on healthcare workers too. So So now we find creative ways to treat the sick. And we all knew that we couldn't come in contact with anyone because there were distance regulations. So if we were going to continue healthcare, we had to find a way to do it where we were a little further away from the patient. So virtual health became very important. And I heard some of the presenters talk about virtual health and how that works. And we saw a dramatic increase in virtual health. So the IT response, how do we deal with it? IT was essential. They told every single one of us to get away from the hospitals. Don't go there unless you have an absolute mission critical life or death situation. Do not go into the hospitals. And even if you did, they would take your temperature and they would give you a gown and a mask and some eye protection. So, but we just didn't go anyway. And most of us, went home. We worked remotely. So what did we do then? Well, this was kind of how it worked. If you were to see somebody at registration, you probably look like this. And we would still do the same process of registering someone. You probably weren't in a doctor's office at that time. Most of the doctor's offices closed, and they would just go and treat the inpatients. If you did happen to go into a hospital, then you would see somebody look like this if they were actually going to come and see you. If you didn't, more likely you were going to see something like this in the room. You will see somebody talking to you through a computer. And I actually experienced this myself, one time during COVID. So I saw how it works. So you will see this is a virtual health machine that has a camera, has a speaker, and it may even have a thermometer and a stethoscope and a place to put your finger so you can get your blood pulse ox. So the doctor can actually get some vital signs from you. The nurse and all of them would go in and do the vital history. If they had to do vital signs, they would do it. And then the provider would never come in the room unless they had something, a procedure they had to do on you. Then they would go ahead and do the same thing. They would refer you to the next step in the process. Of course, if it was something they consider not critical, it might not get scheduled right then because the hospitals just weren't doing those procedures. And as we all remember, nobody wanted to go near a hospital because that's where you thought it was a hive of infection. At least that's the way everybody thought. And it kind of scared the healthcare workers too at one point. And they got tired and they did get sick too. Now, what made it even worse was that if anyone was exposed to COVID, if their personal protective gear failed, then they would be at quarantine. So there's a staff member you don't have anymore. And just keep that in mind when I'm about to move along. But the schedule was full. Only reason was because there was a long backlog because we weren't seeing as many patients, but some people were still sick. They had to wait a lot longer. And also some of the staff was short because they were actually covering in the hospital. They weren't covering in the doctor's offices. So to get an actual physician visit took a long time. You could always go to the emergency room and the urgent care centers and the health parks. And that was kind of really where you're going to get your care. So we tried to, conform to the rules of distancing and no contact, and that's kind of what we did. Now, healthcare, we sent home 1,000 staff members or more to work. 400 plus of those were IT. This was an actual picture of what it looked like, and this was actually our support center. So they weren't at their desks anymore, and so they were actually at home. But here was the beautiful thing was that we have done remote before, but just not every single person at one time, because every single person in these cubicles takes call. Matter of fact, this little doll here is the symbol we used to put on our cubicle that would say, I'm on call, I'm not coming into the office today. So they're working through the night. So we were already equipped to work remotely. Most of the IT people were. But what wasn't equipped was the accounting staff. We still had to get the bills paid, but they didn't want them to come in the building either. Human resources, the help desk, schedulers, medical coders, all of those were working on the computer, didn't see patients. They wanted to send them home. So we are having several thousand employees that are starting to work at home. Now, how do we do this? Well, we had to come up with a standard workstation platform that all departments could use, mimicking the one that they had at the hospital. Laptops were fine, but we didn't always have them. So what we did was we sometimes sent the staff home with what they had at the hospital or at their workstation. Well, teleradiology, the radiologists didn't go to the hospitals if they didn't have to, so we sent them home with high resolution displays, and I'll give you some statistics on that later. How am I doing? Okay. And information security seriously expanded. You have this many people who are working remotely. They're on their own networks, not the hospitals, because we were able to secure our wide area World Wide Web solution. It's not so easy to secure it when they're at their home first, and then they get on the VPN. So there's this much bigger security risk there. And then we also use mobile apps. We didn't use our phones on our desk anymore. Our our communication was almost always our cell phones. So then we had to secure our mobile apps as well. All of their meetings were done in telecommuting. We had no in-person meetings. They were all Zoom, Teams, or ServiceNow was our service problem tracking software. But what else also kind of hurt was since we had so much challenges with COVID and staff getting quarantined and getting sick, we still had ICUs filling up. They would use anyone who had clinical credentials, whatever department they worked in, whether they're in human resources, accounting, IT. A lot of our IT staff were RNs and respiratory therapy. I'm an RT, radiologic technologist myself. So we were subject to be redeployed to work in the hospital whereas needed. And it really hit our electronic health record group the most because they were almost entirely nurse practitioners and registered nurses. So the redeployment went, so it would be maybe a month or a couple months, maybe 3 months before you saw those staff members again. So what did we do? Virtual health equipment went up 300% because we bought a lot more of those robots, leased some of them, and also our accounts expanded. We had virtual health already. And that was the beautiful thing. We just basically expanded what we did. Teleradiology, we added 35 remote workstations. Now these are the high-res ones, the big monitors that you see in the hospitals. So that's a 50% increase in our footprint outside the hospital. VPN access went up significantly. I don't have an exact statistic, but it is definitely at least 3 or 4 times the utilization we had before. We even had to make adjustments in our bandwidth, and we even upgraded our platform during the COVID pandemic. Not saying that the existing provider wasn't doing it, it's just that we found someone that could, and that worked for us. It was a vendor we had already. We had to increase our security stance because the staff's at home. We had to put in web filters, whitelist agents, and we were doing vulnerability scans and remediation continuously because our risk had increased. The staff moved their office equipment and PC equipment to the home. We had to actually adapt it because it was made for the hospital, not for home. And then what did the executives do, the C-suite? They actually created a task force on how to sustain remote work. So that was interesting because they kind of realized that we're doing pretty well working at home, at least IT and all of the support things like accounting and human resources and coding. So we were having an awful lot of data going outside the hospital and back. Now post-lockdown, what do we find out? Okay, the restrictions came out. We're allowed to go see patients again. People are starting going back to the office. You know, they're still spacing out the appointments because you can't fill the waiting rooms anymore. But we're going better with that. We found that IT worked very well this way. I actually have found in my staff that if they're near their phone all the time and not in a facility, they have very few extractions, but they can cover multiple facilities at once because the help is all the same. And they will end up seeing and handling more cases per day that way. Remote and telecommuting is likely to continue at some level. I like myself, I have been out not going to the office since the previous March. That's 1.5 years. And nobody knows the difference really, except that I'm getting more work done. Teleconferences are replacing traditional in-person meetings. You really have to have a reason to have an in-person meeting now. We only do it once a quarter just because we want to stay in touch with each other. You know, we don't want to get too estranged with each other. And no, this is not me on call, although it was one of my neighbors. Okay, we also found online chat with providers was preferred for non-critical care. Before, we could hardly get anyone to use the online talk to your doctor, talk to your nurse features that we had. We've had them all along. Nobody really utilized it that much. But we found it was especially useful for people with positive COVID tests because they wanted an immediate answer because now the clock is running. They gotta stay home from work. So they want to get an immediate, go ahead and start treatment. So, and then quarantine if necessary, so they can go and get through it and get back to work as soon as possible. And also see their family members and all the other things that go along with it. It's not just work. So the online chat worked and improved itself, and we found that the patients really embraced it. Telehealth medicine wasn't strange anymore. They didn't feel like the doctor was avoiding them. They didn't feel like they're giving you secondary quality care. They actually looked at it as just as good as in person now. And if anything COVID did, it proved that concept. Now, post-COVID workflow, they would use a mobile app, schedule their appointment. They never really did the mobile app that much. We've had it. We had to have it because of meaningful use and all of the other regulations, but it just was something we couldn't really get them on. They'd rather go see that person. I guess that was what most people did. You would still get the medical assistants. They won't be locked down, with the Tyvek suits and all anymore. We would still look a little bit more approachable. But we would also, instead of mobile, you can request a virtual a visit, and then you also might have a chat with your doctor online. That is starting to happen a lot more. We have hospitalists and physicians who are on all day long on the computer talking to patients instead of visits, and so that's taken off. And so the process really has not changed much, but how we access it really has. And now the schedule is full, but there is almost no backlog anymore because online is now an option and is accepted as normal. How about that? Okay, so anyway, the conclusions, I think I finished on time, is healthcare will never go back to the way it was before. We don't see that. So that's what all the executives are saying that I hear of. And that's just my opinion, what I've heard. Maybe other places have a different opinion. But from what we see, it's not going to go back to pre-COVID. Patients have more options and control over what they do. I mean, remember when before you couldn't make your hotel reservations, now you can go online and do it. Which do you prefer? That's starting to happen in healthcare. Remote work is permanent. We're going to be working home. They're actually looking at the downsizing our office space footprints. We're going to stop. We're already terminating leases on big buildings now. So we're going to save the money on that. And cybersecurity is now a priority. It always was a priority, but now it's really a priority. It's now one of the top priorities, on the top tier. And I can tell you how much time I spend with cybersecurity. But it's okay because we want to be secure, and especially now that we're working remotely, it's even it kind of throws us at risk. But if we're doing everything right and following something what all the people on the program today was saying, we'll be fine. Cloud hosting now is being taken seriously. I don't want to hurt anyone's feelings here, but a facility our size, we had an enormous amount of data, and our servers next to us made us feel a lot better. But now we're actually realizing that the cloud hosting has very good resources, and there are certainly when we were expanding our telehealth, which was cloud-based, it didn't really take any time to deploy 100 more sessions and 100 more users because we didn't have to haul a server out there. We could just say, okay, give me a subscription. Here's your URL. Go for it. Especially the doctors who were doing chat and extending the chat platforms. That also worked very well. Those were all cloud hosted. So we are looking now at probably starting to do cloud hosted things when it might have been 2 or 3 years before we wanted to talk about it. And we are more efficient. How are we more efficient? Well, it's like somebody said earlier, you're very secure if you take the humans out of it. Fewer human interactions, the cleaner you are, the less things happen. But if the patients want to bypass the admissions step and the workup step and just go straight to the doctor, they can now, and that gets them to the answer that they want. So we're more efficient that way, and also the fact, like I said, like right now I'm sitting here working. As soon as I get done and hang up, bang, I'm right now back on the hospital's payroll doing their work. Yeah, I know I'm looking at it wrong. I know it's supposed to be on the program, but you know how it goes. But we get a lot more work done now this way. So I hope I made any sense at all.